All right, it is 12 o'clock, 12:01, so we'll go ahead and get started. I want to welcome everyone to Medical Grand Rounds. Really happy that we are back in person, and we're almost done for the year. We only have 2 Grand Rounds lectures left, and so thank you to Anjeli for helping to close out our season. Next week will be the final Medical Grand Rounds of the year. Keep an eye out for next year's schedule. Jennifer and I are getting that together right now. We'll probably have that out in the next couple of weeks. But there will be a break from the week following next through the start of August. So we'll take a little bit of a summer hiatus. Our final lecture of the year, I will say, is the Blount Lectureship, which should be very special. Dr. Clyde Yancey is going to come out from Northwestern University. He is the Vice Dean for Diversity and Inclusion at Northwestern and also the Chief of Cardiology in their division there. As a reminder, you can get CME and MOC credit for all of our talks this year. And questions will come primarily from our live audience, but our chief medical residents are here following Trivia Bowl last night, so I appreciate that. We're really happy to have them. So now I really am very pleased to welcome today's speaker, Dr. Anjeli Kalra. Dr. Kalra is an assistant professor of medicine in the Department of Medicine here at Colorado in the Division of Allergy and Clinical Immunology. She has a clinical practice that spans multiple hospitals, including UC Health, National Jewish, and the Children's Hospital of Colorado. She's the director of the drug allergy program and the quality lead in the Division of Allergy and Clinical Immunology. Dr. Kalra is also an accomplished leader in education, as well as a tireless mentor, and she serves as the director of the Allergy Immunology Resident Elective Rotation, as well as the Global Health Lead for the Division of AI. She's a core faculty member in both the NJ Allergy Immunology Fellowships, as well as the CHCO Allergy Immunology Fellowship. She did her undergrad work at the University of Pennsylvania, where she graduated magna cum laude. She was a medical student at Thomas Jefferson University and then came here to Colorado for her internship and residency and stayed on for her fellowship training in allergy and immunology at National Jewish. She's also currently getting some advanced training. She is one of the members of the Leaders in Informatics Quality and Systems Fellowship, or the LINKS Fellowship, which she'll complete next year. Dr. Kalra is a sought-after speaker who addresses issues around drug allergies, severe allergic reactions, and other related topics, both on the local, regional, and national levels. I mentioned that she's a leader in education. She also happens to be very good at the teaching part of that. She was recognized with the Gold Humanism Honor Society Award in 2015. She was recognized as the Excellent Patient Safety Role Model in 2019 from the University of Colorado Residency Program. And then she was awarded the Children's Hospital of Colorado Excellence in Teaching Award in 2020, 2021, and 2022. I'm going to assume they just haven't announced 2023 yet. It really is a pleasure to have Anjeli Kalra here to give Medical Grand Rounds.
Oh, thank you for that kind introduction. So my name is Anjeli Kalra. Again, I'm in the Division of Allergy and Clinical Immunology, and today I'm going to be presenting on the importance of penicillin allergy delabeling. Please bear with me. My voice is a little tenuous from a viral upper respiratory tract infection, so hopefully I do not lose my voice during this presentation. I have 4 major learning objectives for today. First, we will be talking about why penicillin allergy is a problem that we should all care about. Next, I'm going to review drug reaction classification and preferred evaluation methods to set the stage for discussing the ins and outs of penicillin allergy delabeling and its impact on patient care. And finally, we'll talk about new guidelines in antimicrobial allergy and what antibiotics you can use in patients with penicillin allergy. So we're going to start off with a patient case. A 63-year-old woman with a past medical history significant for hypertension presents with a 7-day history of shortness of breath, productive cough, and fever. Chest x-ray shows evidence of a left lower lobe infiltrate. She has a new oxygen requirement of 3 liters, but other vital signs are stable. Blood cultures are obtained, and workup is negative for pulmonary embolism and acute coronary syndrome. The patient has a documented penicillin allergy. So you go the extra mile and you ask her about her penicillin allergy. And she says that she had a localized rash with amoxicillin 7 years ago without other associated symptoms. She is diagnosed with community-acquired pneumonia and is started on levofloxacin and admitted to the medicine service. She is discharged home after a 72-hour hospital stay, but unfortunately, 5 days later, she develops abdominal pain, diarrhea, and leukocytosis and returns to the hospital where she is found to have C. diff. She is started on oral fidaxomicin and requires readmission. One day later, she experiences symptoms of delirium, and of course, her primary team focuses on treating her delirium, but this further prolongs her hospitalization. 1 week later, her mental status improves, but she is left significantly deconditioned and remains inpatient to work with physical therapy. So after 16 days in the hospital, she spends another 2 weeks in rehabilitation and is then discharged home with her daughter. So in this case, this patient's penicillin allergy resulted in poor outcomes. First, the unnecessary use of levofloxacin, resulting in infection with C. diff and readmission, resulting delirium, deconditioning, and discharge to a rehabilitation facility, and increased length of stay, as well as increased hospital costs. Could this have been prevented? And the answer is yes. So this patient's penicillin allergy, and we'll be addressing this today, is considered low risk. She had a benign cutaneous reaction 7 years ago with amoxicillin. So certainly before this admission, she could have been evaluated for this and delabeled, or even delabeled during her admission. But also importantly, because her penicillin allergy is low risk, it would have been perfectly appropriate to treat her with a cephalosporin. So why is evaluating penicillin allergy important? First, is reported in approximately 10 to 15% of adults and children. Over 32 million people in the US have a penicillin allergy label. However, a vast majority of drug labels are inaccurate. Penicillin allergy wanes over time in a large percentage of patients. So after 10 years of having a reaction to penicillin, 85% of patients are no longer sensitized. And after 20 years, 99% of patients are no longer sensitized. Penicillin allergy has a significant impact on patient care as well. So penicillin allergy label is associated with increased antibiotic costs, delay in appropriate antibiotic administration, and as you saw in our case, increased risk of enterococcus, MRSA, and C. diff infection, increased likelihood of surgical site infections, longer hospital stays, and increased risk of readmission and death. This table, published in the New England Journal of Medicine in 2019, shows here that a penicillin allergy label is usually acquired during childhood. Up to 20% of the population engaged in medical care may be penicillin allergic, and numbers really vary between 10 to 20%. And this results in personal health implications and public health implications. As I mentioned, the use of more broad spectrum antibiotics is oftentimes found in patients who are penicillin allergic, as well as resulting in antibiotic resistance and higher rates of C. diff. And only less than 5% of patients who are labeled penicillin allergic are truly allergic. This study, published in one of our major journals, JACI in Practice, in December of 2022, showed that a penicillin allergy label is associated with worse clinical outcomes in patients with bacterial pneumonia. The authors looked at two cohorts, a cohort of patients with bacterial pneumonia with penicillin allergy and those without. And they looked at risk of hospitalization, ICU level of care, and mortality 30 days after a pneumonia diagnosis, as well as antibiotic prescription patterns. And what they found was in the penicillin allergic group, 20% were more likely to be hospitalized, 10% more likely to require ICU level of care, 8% more likely to die from pneumonia, and 17% more likely to use a non-penicillin antibiotic. There's also a financial incentive of penicillin allergy delabeling. So this study, conducted by Sousa Pinto and their group, looked at two strategies for patients with a penicillin allergy label: diagnostic testing versus no diagnostic testing. And we'll be talking about testing later in this presentation. So they built decision models to project the economic impact of these strategies, and they found cost savings in all of the models built. In inpatients, penicillin allergy delabeling resulted in $1,444 saved per patient in the US, and penicillin allergy delabeling in the outpatient setting resulted in $256 saved per patient. As I've mentioned before, there are also significant positive outcomes of penicillin allergy delabeling, such as, again, appropriate narrow spectrum antibiotic use, reduction in drug costs, reduction in mortality, and readmission. So now that you understand why penicillin allergy is important, I do want to go through drug reaction classification and preferred evaluation methods so we can set the stage for how the ins and outs of penicillin allergy delabeling impact on patient care and what you can do in your own practices to help assist us with penicillin allergy delabeling. So there are two different types of adverse drug reactions, type A adverse drug reactions and type B adverse drug reactions. Type A ADRs comprise a majority of drug reactions, and these are pharmacologically predictable, dose-dependent, non-immune mediated, such as nausea with Augmentin. Type B ADRs are pharmacologically unpredictable, non-dose dependent, and immune mediated. So drug hypersensitivity accounts for up to 6 to 10% of all ADRs. Other type B ADRs include serum sickness, drug-induced liver injury, drug-induced vasculitis, which I will not be talking too much about today. When we specifically talk about drug hypersensitivity, there are two types, immediate and delayed hypersensitivity. So immediate hypersensitivity is what we're focusing on today, but immediate hypersensitivity reactions are also called IgE-mediated reactions. These are type 1 hypersensitivity reactions that typically occur within 1 hour of medication administration. So signs or symptoms of these reactions are going to include angioedema, urticaria, nausea, vomiting, low blood pressure, bronchospasm. And the way that we evaluate for these reactions are typically by a graded oral challenge, which I'll be discussing in more detail shortly, and potentially skin testing. If medications are necessary in patients who have immediate hypersensitivity reactions that are confirmed, a desensitization can be offered as treatment. Delayed hypersensitivity reactions, on the other hand, are T-cell mediated type 4 hypersensitivity reactions and really range from mild to severe, mild being maculopapular drug eruptions and more severe reactions being drug-induced hypersensitivity syndrome or Stevens-Johnson syndrome. Typically, these reactions are going to occur 7 to 10 days after medication administration, but can really span in terms of the time course. And our methods for evaluation are primarily clinical history, but we do have certain types of testing like patch testing available in specific scenarios. I do want to briefly bring up the concept of direct mast cell activation. So this replaces pseudo-allergy or anaphylactoid reactions that you may have heard about. These are non-IgE mediated reactions that occur through direct mast cell stimulation via the MRGPRX2 receptor. So there are numerous common causes of these direct mast cell activation reactions, the most common being radiocontrast media, but also including non-steroidal anti-inflammatory drugs, opiates, vancomycin, fluoroquinolones, for example. And these drugs, again, these cause non-IgE mediated reactions, directly activating through the mast cell, resulting in degranulation of the mast cell. These reactions are different from IgE-mediated reactions because we tend to use pretreatment. So pretreatment with antihistamines can actually prevent these reactions from occurring, which is not the case for IgE-mediated hypersensitivity. But also these reactions are dependent on drug concentration, underlying comorbidities, and multiple other factors. I want to introduce the concept of pretest probability and drug allergy evaluation. So I think it's a common misconception that in allergy and immunology, we have skin testing for everything. And I wish we did, but we don't. And a majority of drug allergy skin testing is actually not validated, with the exception of penicillin. So when we do drug allergy skin testing, we're using non-irritating concentrations, so we don't cause a false positive. However, the negative predictive value is really unknown. So when we think about drug allergy evaluation, pretest probability or the likelihood of having a true drug allergy is really what hinges our evaluation. So factors that increase the risk for immediate hypersensitivity to penicillin would be node administration before the course related to the suspect reaction, so sensitization, a period of sensitization, reaction within 1 hour after the first dose of a subsequent course, no known tolerance of administration subsequent to the suspect reaction. So if someone has received a penicillin since their reaction and tolerated it, that rules out an IgE-mediated reaction. Parenteral administration, recent reaction, typically within the last year, and then a reaction consisting with urticaria or some combination of respiratory, cardiovascular, or GI symptoms. So pretest probability is really essential in how we evaluate drug allergy. For immediate hypersensitivity, our standard modality for evaluation is going to be a drug challenge, 1 or 2 step, which I'll talk about in more detail in a moment. Skin and intradermal testing is really used in certain scenarios. So skin testing in general, as I mentioned, has limited value because there's a risk for false positives. The negative predictive value is unknown. But again, it can be performed in patients who do have a history of anaphylaxis, are at high risk for IgE-mediated reactions. But drug allergy evaluation, again, hinges on the drug challenge. So if a patient has a pretest probability that is likely in accordance with IgE-mediated reactions, and their history is low risk histories being benign cutaneous reactions greater than 5 years ago, childhood history, and I'll talk about more about this concept in a moment, we will proceed with a single or graded dose drug challenge. A single dose would essentially be giving the medication and monitoring the patient for 1 to 2 hours. A graded dose challenge would be giving the medication at 10% of the full dose, monitoring the patient for about 30 minutes, and then giving the remainder of the full dose and monitoring for 30 to 60 minutes. And that's what we typically do inpatient or in our clinics. Now, for patients who fail their drug challenges, or for patients who have a clear history of anaphylaxis or positive skin testing, a drug desensitization is an option. However, drug desensitizations are only used in patients with IgE-mediated or immediate hypersensitivity reactions. They're contraindicated in patients who have severe cutaneous adverse reactions, such as Stevens-Johnson's, drug-induced hypersensitivity syndrome, drug-induced liver injury, for example. So now that you understand drug allergy concepts, let's talk more about the ins and outs of penicillin allergy delabeling, its impact on patient care, and how we can introduce drug allergy delabeling into all of our clinics. So first, to start off with penicillin structure, just to remind everyone, penicillins are composed of a beta-lactam ring, a thiazolidine ring, and an R1 side chain. So penicillin spontaneously degrade and covalently bind to form protein, to form haptens. So the hapten complex is really what drives the IgE-mediated reactions. The penicillins then degrade to form major determinants of penicillyl complex and benzyl penicillin, and then they degrade further to minor determinants, which include benzyl penicilloate and benzyl penyloate. The reason why this is important is because this is what we're skin testing to when we're doing penicillin skin testing. So as I mentioned before, just to reiterate, penicillin allergy is the most commonly reported drug allergy affecting 10 to 20% of the patient population, but very few patients are actually allergic, less than 5%. And again, after 20 years, fewer than 1% of patients will maintain sensitization to penicillin. So I have a few questions peppered in this presentation. You certainly don't have to answer. It's just to really drive home a few concepts. The question 1 is, you're seeing a 72-year-old man with a past medical history significant for hypertension, hyperlipidemia, and osteoarthritis for general follow-up. He will be undergoing an elective knee replacement in the coming months, and he has a history of a possible rash to amoxicillin during early childhood. Which of the following is the next best step to evaluate this patient's reaction to penicillin? So A would be penicillin skin testing followed by challenge to amoxicillin. B would be direct oral challenge to amoxicillin. C would be avoidance of all beta-lactam antibiotics. And D would be to ignore this piece of information and move on, which I completely understand. Now, the answer here is actually B, direct oral challenge to amoxicillin. And that brings up a very important concept of risk stratification. So we have seen over the last few years that movement to direct oral challenge in patients with low risk penicillin allergy is really standard of care. And the reason why this is important is because not only is it safe, but it is something that everyone can really incorporate into their clinical practice. I'm going to try to prove that to you today. But there are multiple risk stratification tools in penicillin allergy. This is just one of them. This is a table from an article by Ian Matteo et al. In JACI in 2021. And they are risk stratified based on clinical history. So the first category on your left would be very low risk patients. These are patients with adverse reactions to penicillins. We had GI upset with augmentin, headache, yeast infections, or a family history of penicillin allergy. My dad had a bad penicillin allergy. This is not hereditary. So in general, these patients can be directly delabeled. So remove the penicillin label from their allergy list and move on. Low-risk patients would be patients with a benign cutaneous reaction. In this article, they say more than 10 years ago. We're now accepting definitions of greater than 5 years ago. A childhood reaction, unknown childhood reaction, or a reaction that happened generally greater than 5 years ago that did not require treatment. So these patients can move directly to oral challenge to amoxicillin, and that could be either a single dose, which we'll talk about with amoxicillin, or a graded challenge. And then patients with intermediate or high risk histories, anaphylaxis, for example, then you would want to refer to allergy or consult us for further evaluation. The PenFast tool is an excellent clinical tool that I think all of you should be familiar with. This was developed by Jason Trubiano's group out of Australia and uses 3 different parameters when looking at penicillin allergy history and risk stratification. So the first would be a reaction less than or equal to 5 years ago. So you get 2 points if your reaction occurred in the last 5 years. If you had anaphylaxis, angioedema, or a severe cutaneous adverse reaction, like Stevens-Johnson's, you would get 2 points. And if treatment was required, such as epinephrine, you would get 1 point. So a score of less than 3 is considered low risk. A score of 0 is considered very low risk. And the negative predictive value of this scoring system is 96.3%. Their group is now piloting the PALIS protocol, which is looking at the safety of this decision tool in direct oral penicillin provocation challenges. So just to briefly talk about the type of testing that we do. So if you have a patient who has a high risk history of anaphylaxis to penicillin and you refer them to us, we would generally do penicillin skin testing in these scenarios, depending on the clinical history. It does have a high negative predictive value, and it is safe to perform in pregnant patients, which I will talk about. We follow that with a challenge to amoxicillin, and the reason why we do that is because though penicillin allergy skin testing has a high negative predictive value, we want 100%, of course, but we're going to be using aminopenicillins for these challenges because there's a rare group of patients that can actually have IgE-mediated reactions to aminopenicillins due to the specific R1 side chain, very uncommon in the US, but also amoxicillin is very cheap. When we do penicillin skin testing, we do 2 different types. So percutaneous skin testing, which is just your standard skin prick testing that we do in our office. And we do that to, again, the major and minor determinant. And intradermal testing, which is under the skin testing, sort of like a PPD. And we also do that to our major and minor determinant. We then go on to oral challenge, but direct oral challenge, skipping the skin testing portion, as I mentioned, is really what we're encouraging for a majority of patients. So low to moderate risk adult patients, almost all pediatric patients, and also increasingly low risk pregnant patients. Dosing will be around 250 to 500 milligrams of amoxicillin. And in many cases, in low risk history patients, we recommend just doing a single dose of amoxicillin. Direct to oral challenge, this strategy is safe and effective. So this meta-analysis looked at 13 studies with a sample size of about 1,200 patients. All of these patients had low-risk penicillin allergy, mild cutaneous reactions, reactions that occurred greater than 1 year ago, and only 3.41% of patients had mild immediate reactions, localized urticaria, or delayed reactions, and there were no reports of anaphylaxis or severe adverse reactions. 96.5% of patients that were penicillin allergic were delabeled. So as I mentioned, single dose challenges with just amoxicillin 500 milligrams are really being stressed in our literature. So this study that was published in Clinical Infectious Diseases in 2021 looked at inpatient delabeling for low-risk penicillin allergic hospitalized patients. And this was primarily done by non-allergists. These patients underwent single dose oral amoxicillin challenge or direct label removal based on history. So in the direct delabeling group, these patients, again, had adverse reactions to penicillin, they were directly delabeled. And in the oral challenge group, these patients were identified as low-risk patients, and they used the definition of an unknown reaction greater than 10 years ago, childhood rash, or maculopapular eruption, and they were directly challenged to a single dose of amoxicillin, 500 milligrams. And only 6 of 200 patients who were challenged had mild delayed cutaneous reactions, no reports of anaphylaxis. I do briefly want to talk about specific IgE-mediated reactions to piperacillin tazobactam. So this is being increasingly reported. These patients are having specific reactions to the side chain of piperacillin tazobactam, but can tolerate other penicillins. So just keep that in mind. And then I also want to touch on penicillin allergy in pregnancy. So it used to be that penicillin allergic patients who are pregnant would be admitted directly to the ICU for a desensitization. However, over the last several years, this has drastically changed. 10% of pregnant women have a penicillin allergy label. That is a large number of patients. All first-line antibiotic regimens for infection during pregnancy include beta-lactam antibiotics. And patients with a penicillin allergy label have an increased risk of C-section delivery, post-C-section wound complications, and longer hospital stays. In addition, 1 in 3 women have group B streptococcus, and penicillin is the preferred treatment for GBS. Penicillins are also used for pregnant patients who develop fevers during delivery or prolonged rupture of membranes. So penicillin allergy evaluation in pregnancy, and I want to stress this, is safe. Skin testing followed by challenge to amoxicillin has been looked at in numerous studies in pregnant patients and is safe and well tolerated. And in fact, it's now recommended and supported by ACOG. However, we are also finding that direct oral challenges in low-risk pregnant patients is also likely safe. So in this second question, this is just to bring up the point of what to do in pregnant patients with penicillin allergy. You have a 22-year-old woman who presents to your outpatient clinic with abdominal pain. As part of your evaluation, you order your urine pregnancy test, which returns positive. And then a few days later, you receive the patient's blood work, which reveals a positive RPR. The patient reports an unknown childhood reaction to penicillin. So what is the next best step? Do you admit the patient to the ICU for a penicillin desensitization? B, do you directly oral challenge to amoxicillin in your clinic? Or C, do you refer for penicillin allergy skin testing followed by an oral challenge to amoxicillin? Now, it's a bit of a trick question, but B or C would be absolutely correct in the scenario based on shared decision making. But A certainly would not be necessary. And I think previously, when we're admitting patients for penicillin desensitization, this results in increased hospital costs, longer length of stays, increased risk of infection, and can also delay the time that we're taking to treat these patients with syphilis. So there's a growing body of evidence for direct oral challenges in low-risk pregnant patients, and is really encouraged, especially in rural settings where patients cannot get in to see an allergist in time. So Mac et al., this is a study from Canada in Jackie in Practice in 2022. They took patients with a PenFast score of 0. So these are very low-risk patients, and directly challenged them to amoxicillin 500 milligrams. 245 patients were enrolled. 216 were deemed low risk, and 207 underwent direct oral challenge. 203 had no adverse reactions and were delabeled, and only 4 had benign delayed cutaneous reactions, did not require treatment, no adverse outcomes reported. I do want to briefly focus on what we're doing here at the University of Colorado. In addition to in our outpatient clinic, we have many quality improvement programs directed to penicillin allergy delabeling in pregnant patients, and patients who are immunocompromised, and transplant candidates. But on the inpatient side, Dr. Anita Modgill and I, with the help of Sam Porter and Misha Wang and in antimicrobial stewardship, we are working on this project that will hopefully go live in August to encourage delabeling of low-risk penicillin allergic patients on hospitalist services or medicine services driven by non-allergists. So essentially, what we recommend doing is first obtaining a history of penicillin reaction. And that includes performing risk assessment by PenFast score. So in terms of the risk assessment with the PenFast score, that's again going to include a reaction that occurred less than 5 years ago, anaphylaxis or angioedema, severe cutaneous adverse reaction, or if treatment was required. If the history shows no risk, score would be 0, and the patient has an adverse reaction to penicillin, such as nausea or a family history of penicillin, we recommend direct delabeling. And in patients with a PenFast score of less than 3, we recommend single dose oral challenge with 500 milligrams of amoxicillin. That would be included in an EPIC order set, so hopefully this is easy to use. Patients are monitored for 1 hour after direct challenge and are delabeled. And of course, for patients with high risk of penicillin allergy, you would contact us on the Allergy and Immunology Consult service. We're always available for questions. And hopefully, as I'll talk about momentarily, hopefully this increases the likelihood of penicillin allergy delabeling for patients who need penicillin antibiotics, but also for patients in the general population who can just benefit from penicillin allergy delabeling. So in the final moments of my time, I'm going to be talking about new guidelines in antimicrobial allergy and what antibiotics you can and can't use in patients with penicillin allergy. And I'll be finishing up with tools that you can use in your own practices as residents, as fellows, as hospitalists, as primary care providers to help to delabel penicillin allergy. So my third question and my final question is, you have a 25-year-old woman at 24 weeks estimated gestational age who presents to your clinic with a 3-week history of fever, sinus pressure, and green nasal discharge. You would like to treat her for acute bacterial sinusitis, and she has a childhood rash with ceftonir. Which of the following antibiotics is the best choice for this patient? So would it be A, amoxicillin, B, levofloxacin, C, doxycycline, or D, none of the above? So the answer, and I'm sure you're thinking this, is amoxicillin. And the reason why is because this patient has a low-risk cephalosporin allergy, and anyone with an unverified non-anaphylactic history of an allergy to a cephalosporin can receive a penicillin without any further testing. So we will talk about that. But in general, cephalosporin allergy affects 2% of the population, and this, like penicillin allergy, wanes over time. It's largely due to the R1 group side chain cross-reactivity rather than that core beta-lactam. We don't have validated skin testing, but we do have non-irritating concentrations. We hardly ever do skin testing to cephalosporins other than in certain scenarios. And again, pretest probability is critical here. So urticaria, for example, within the first hour of the subsequent course of the first dose resolves within 1 day and occurred within the last 1 year. So what is the true cross-reactivity between penicillins and cephalosporins? So patients with confirmed penicillin allergy, so this is patients with a history of anaphylaxis, a positive skin test, 16% cross-reactivity with a first or second generation aminocephalosporin, and only 2% cross-reactivity with a third or fourth generation cephalosporin. So patients with unconfirmed penicillin allergy, this is a majority of the patients that we're seeing, cross-reactivity is minimal. So in 2022, last fall, our societies updated our drug allergy practice parameters. And these are important takeaway points that I hope that you remember from today. So again, primary allergy to penicillin, if a patient has an unverified non-anaphylactic penicillin allergy, you can use any cephalosporin. You do not need to do a test dose. You can use any cephalosporin. For patients with a history of anaphylaxis to penicillin, you could administer any non-cross-reactive cephalosporin. And I'll show you a table that you could reference in a moment. But cefazolin, for example, which is commonly used, has no cross-reactivity to penicillins. So no matter what the history of your reaction to penicillin is, a non-cross-reactive cephalosporin like cefazolin can be used. If you have a primary allergy to cephalosporin, so an unverified non-anaphylactic cephalosporin allergy, you can go ahead and administer penicillin without any further testing. And if you have an anaphylaxis history of cephalosporin, depending on which cephalosporin, we would then recommend allergy involvement and potentially penicillin testing. But what about carbapenems and monobactams? Completely safe to give carbapenems to penicillin allergic patients, and safe to give aztreonam to penicillin and cephalosporin allergic patients, with the exception of ceftazidime, because there is an R1 side chain that's shared. So this is a table, may be difficult to see, but this is just one of the many tables that we have available that shows cross-reactivity between cephalosporins and penicillins based on that R1 side chain. So if you're ever wondering, what can I give my patient, you can take a look at these tables. This is published in the Practical Guidance of Evaluation and Management for Drug Hypersensitivity. But if you look on our major for example, our Quad AI website, you'd be able to find this. The red color indicates identical side chain cross-reactivity, and gray is similar side chain cross-reactivity. I still have not memorized this table, so I still use this all the time. So in terms of penicillin allergy pros, I want to bring up a few major points that I talked about today. Over 90 to 95% of patients with a listed penicillin allergy are not truly allergic. A penicillin allergy label can increase patient morbidity and mortality along with healthcare costs. And delabeling penicillin allergy is cost-effective and can positively impact patient care. Finally, we know that low-risk penicillin allergic patients can be directly challenged to amoxicillin with observation. And there are no reports of anaphylaxis or severe adverse reactions in this patient population. And PenFast is a useful tool for risk stratification. Patients, again, with a non-anaphylactic penicillin allergy can receive any cephalosporin. Patients with a non-anaphylactic cephalosporin allergy can receive any penicillin. And finally, patients with anaphylaxis to penicillin can receive cefazolin. No further testing is required. So I want to end with these last two slides. I love this editorial in the British Medical Journal in 2022, and it says, delabeling penicillin allergy is not rocket science. It is not rocket science. However, it is something that is important, and you can do in all of your clinics and inpatient for your patients to reduce morbidity and mortality. And so there have been numerous studies looking at non-allergist driven models for penicillin allergy delabeling. And again, we know that it's safe and effective if we are using low-risk penicillin allergic patients. So that would be with a PenFast score of less than 3. If we have supplies on hand to deal with reactions, including intramuscular epinephrine, oral cetirizine, and if these patients are observed for 1 to 1.5 hours, if we have all of those things, penicillin allergy delabeling is safe and effective and has tremendous outcomes on patient care. One thing I think that's important is taking precautions to reduce relabeling. So that means removing the allergy label in EPIC, which I think is actually oftentimes not done. Documentation with a procedure note, and making sure to send this documentation to all involved providers, and making sure that penicillin allergy is delabeled from all other healthcare systems. In this table here, we can see, so red is frequently delabeling of penicillin allergy. So we can see really outpatient allergy clinics are the only place where we're frequently delabeling penicillin allergy at present. And occasionally we have penicillin allergy delabeling initiatives in the ICU and inpatient units, but not so commonly in outpatient general medicine, outpatient general pediatrics. Our goal is to increase penicillin allergy delabeling in these clinics, especially in rural areas where there's not good access to allergists or immunologists. We know that the ratio of penicillin allergic patients per board certified allergist exceeds 5,000. And there's long outpatient waiting times. There's lack of inpatient allergy consultation services. And so we can't do this alone. And this can safely be done in your practices for low risk patients. So if any of you have any questions about penicillin allergy or penicillin allergic patients, please feel free to contact our service, either through DocLine or through consultation. We're happy to work with you to effectively delabel these patients, especially patients who are at increased risk of complications, like pregnant patients with a penicillin allergy label with syphilis, for example. We want to delabel these patients efficiently and effectively. So that's all I have for you today. I will open it up for questions, comments, discussion, but thank you.
Dr. Kalra, thank you very much. Throw it open to questions here.
Thank you so much. That was one of the most practical grand rounds I've heard in a long time, and I really appreciate that. And I was thinking of your thoughts on a patient that I have. Is one of these people that has 17 drug allergies, and one of them was penicillin, and she's got asthma and sinusitis, gets multiple antibiotics. So she was delabeled by the allergy clinic successfully. So she came in with sinusitis. I gave her Augmentin, and she got hives within an hour. So I relabeled her. Was that the right thing to do, or what do you think happened?
Yeah, I think that's a great question, and I may know who you're talking about, because I see a lot of
I
patients
know
like
you
that.
do.
But I think so. The thing with urticaria is that many patients who are sick, if there's a stressor on the body, many patients are going to get urticaria. Some patients are just prone to urticaria. So as urticaria alone without other associated symptoms, I would say you probably don't have to add that allergy label back. We're always happy to re-challenge the patient or discuss it with the patient. But oftentimes we tend to see this, especially in the pediatric population, very common for kids to have urticaria or rashes associated with viral infections. And it's not necessarily the antibiotic. Especially when someone has 17 things on their allergy list, and it's usually hives. The chances of that person having chronic spontaneous urticaria in settings of infection is very high. So that might be what happened there.
Hi, I agree with Dr. Corbin. Terrific presentation. Question is, what do you do with a patient that presents with sepsis, where the need is very acute and has an uncertain penicillin allergy?
Yeah, so I think, in someone who is very unstable, potentially that is not the time to do a challenge. However, if the patient has relative stability in a low-risk penicillin allergy history, I think it's perfectly appropriate to do a direct oral challenge. However, in general, again, low-risk penicillin allergic patients can receive any cephalosporin. So if there's an equal or alternative antibiotic in the cephalosporin category, then you can also go ahead and use that. So I think it just depends on what the patient's presenting for. But as long as they're not clinically decompensating, I think it's perfectly appropriate to do a challenge.
So, Anjeli, that's presentation, terrific body of work. I have a personal history of having childhood labeling as penicillin allergic. So I won't go to the specifics, but it was a soft call. But my helicopter mother forced me to wear a dog tag until I was old enough to throw it away that said I was penicillin allergic. So in an early stage in this whole process, I had a challenge in our clinic. I think Dr. Stitney maybe Dr. Shockett was in charge of it. I can't remember. But I felt anxiety when I took that pill. And I'm not a very anxious person. So can you, again, I think it's great to have everybody doing this, but there's some patients who will say, I never believed my mother to begin with. Let me have the amoxicillin. But there may be people like me who sort of believe my mother. Could you address that, please?
Yeah, I think that's a great question. We do a lot of penicillin challenges in our clinic, and even in relatively anxious patients, I would say that it usually goes pretty well. But that being said, I think first quoting the literature and talking about most of these patients, their reactions are going to be 20 plus years ago. So the risk of reaction there is less than 1%. In patients who are severely anxious and really are uncomfortable going a direct oral challenge, I think that's when allergy should be involved, and we may end up doing skin testing. But we're also looking for signs or symptoms of an allergic reaction. So this is really going to be the observance of urticaria, the observance of angioedema, very unlikely to have anaphylaxis during these oral challenges, as I've shown you. But subjective symptoms like subjective pruritus, which is common, those are not signs or symptoms of an allergic reaction. And so I think certainly, that comes with, in allergy and immunology, we see this a lot, subjective symptoms when we're doing challenges to foods or drugs. So that does come with time. But in general, I think quoting the literature, being present or just being nearby during an observed direct challenge lowers the risk of subjective symptoms, and then just being reassuring during the process if there are no objective signs or symptoms of allergic reaction. And then, of course, for those patients who really are anxious, getting us involved, and we can always do skin testing, which lowers that anxiety a little bit.
So I'll agree with everyone else over here. This was a wonderful, very pragmatic talk. I want to follow up on that, and then I had a question of my own. The follow-up on that is for someone, there's a fairly large category of people that you're saying we should just delabel, period, without doing any further testing. Do you ever go ahead and give those people a challenge dose so that they feel better about removing penicillin from their allergy list?
Yeah.
Go ahead.
Thank you. And yes, so I think this is a conversation with the patient, right? It's always shared decision making. So if someone feels comfortable directly delabeling, we go for that. But there are many times, especially with family history of penicillin allergy, where someone is just too nervous to directly delabel. A single dose challenge is perfectly appropriate, and there's so low risk that that could be really easily done in any outpatient setting. But I think that's perfectly appropriate.
And so the question I had is, this strikes me as the kind of thing that if we leave it up to us, it's not actually going to happen very often. Whereas there is a fairly large, not the entire, but a fairly large cohort of these patients who ought to be delabeled one way or another, who are so low risk that an MA could do a few screening questions as part of the MedRec, and sort of build that into the workflow, and then send us a note saying this person looks like they don't really have a penicillin allergy. You should address that. And I'm just curious if you've seen QI type projects done elsewhere where the MA was wrapped into this workflow to trigger in the same way they trigger us. This person is overdue for this or that vaccine.
Yeah, I think in allergy clinics that's happening. I don't think so much. I haven't seen data on primary care clinics making this part of the workflow where a nurse or an MA kind of goes through like the PenFast scoring for a penicillin allergic patient, and then that triggers. But we are actually doing that in our OBGYN clinic. So we are working with one specific clinic right now that penicillin allergy label triggers. There's actually a nurse intake visit that they go through. They ask those questions, and then they're actually referred to us for delabeling because it's a specific population. But I think that these are the types of things that we want to do. We want to make penicillin allergy delabeling a preventive healthcare measure that is really done in all clinics across the country, because it is that important. So I think that's definitely a good point.
Dr. Chopra?
Dr. Kalra, this was great. My question is around the issues when I have delabeled patients, but have found when they come back to the hospital that somebody has relabeled them. It's sort of one of those things where, and you can think of the patient in this conversation where someone did something and someone reversed it. That sort of goes back to the whole trust aspect. Are there thoughts or ways to prevent that relabeling from happening? I mean, as a pragmatist, I would even say, should we be the ones labeling these patients in the first place? You stop the problem maybe right before it even happens in some ways. Would love your thoughts on that.
Thank you. I think you bring up some great points. I think with regards to relabeling, so this has actually been looked at in a couple different studies, and over at Children's, there was they published an abstract about relabeling as well. It is rare, but it does happen, and I think there are a couple of things that we can do to limit relabeling. And so the first thing is when we delabel a penicillin allergy in Epic, for example, and this could be in any electronic medical record system, I think it's really important in the comments to write in there, patient had an amoxicillin challenge on this date with this person, before you actually delete the label. Because then what happens is if the patient doesn't remember this or there's some concern, they come back in, they tell someone they're penicillin allergic, and it's pretty easy to add that back on. But when you try to add it back on and you have those comments in there, that might give pause to look back at the note and say, oh, it shows that you have this procedure. So I think documentation of that before removing the penicillin allergy label is important. And then also, there have been studies giving patients, cards or documentation or things to have in their wallet that state that they've been penicillin allergy delabeled on this date by this person, and they carry that around with them. And then, of course, sending this documentation to every single provider that is involved in the patient's medical care is really important. And also making sure that not only the patient knows that they have been delabeled, but caregivers, anyone else involved in the patient's care. But it is still a problem that exists because everybody wants to add an allergy label to someone's chart and nobody wants to remove it. So it is a pervasive problem. And I think that brings up the point about who should be adding allergies to a patient's allergy list. I do think it should be us, because there's so many nuances in drug allergy and intolerances and contraindications. And when you add a penicillin allergy to someone's drug allergy list, again, we know that increases morbidity and mortality. And that's not just for penicillin allergy. That includes sulfonamide allergy in patients who are immunocompromised, and many, many other drugs. So I think that is a bigger problem that we're facing. And I wish it would be easily solved, but I think we are addressing that in terms of, or slowly addressing that in our societies in terms of how we are approaching patients and checking them in and labeling allergies.
We have a couple minutes. I just want to steal one question. What do you do what would you like us to do with the high-risk patients who have had a very long time from their reaction? So they've got a reasonable story from childhood, but now they're in their 40s and 50s. Does allergy want to see them inpatient, outpatient at all? What do you do with those folks?
Yeah, I mean, these patients can definitely still be delabeled. I mean, we see a lot of patients who, I think it depends on the clinical history, right? A lot of times patients will say, as a child, I had anaphylaxis to penicillin. That's still probably technically low risk if, the patient's 50 or 60. So we may actually directly challenge that patient. If a patient's high risk and maybe 5 years ago had anaphylaxis to penicillin, we may do skin testing and challenge with the patient. But I think that we still want to evaluate all these patients, even if the history is anaphylaxis. It just may be through skin testing and challenge. So we always want to see these patients, whether it's inpatient if there's an urgent need, or if it's outpatient if there's a non-urgent need. We want to be involved because we know that the outcomes are so good with penicillin allergy delabeling.
All right. I think you got them all. Thank you very much.
Thank you.